say 1, 2, 3, 4, 5, 6. Let's go ahead, Magda. 1. Just go ahead. Number 1. Physicians and nurse practitioners, please keep your heads up. So, you guys want to go just 1, 2. 5. Let's start again. 1. It's about Jennifer, who is a 59-year-old with cancer, and we're going to focus on pain management. So I just want you to have a discussion, and each one of you, as a discipline, are going to be bringing your own expertise into this case.
Which group are you guys?
You also received a pain card that you actually fold, and it looks like a nice rectangular shape that you can just put in your pocket. And we're going to be using those pain cards during the exercise, and you're welcome to keep those pain cards with you for future use. Thank you. Would you all read it?
Pretty much.
So let's see. Jennifer is a 59-year-old woman with metastatic pancreatic adenocarcinoma. You all understand what that means?
Pretty much.
Metastatic pancreatic adenocarcinoma, that means that it's a cancer of the pancreas, which is very, very bad. And metastasis means that it has spread already. So she has a very bad
Liver mets that we know of, right?
Right. 4 months ago, she developed lower thoracic back pain. So she was having acute pain on her back. She saw her family doctor and then an orthopedic surgeon, but the source of her pain was not actually a habit, so this is very expensive. To continue to have significant back pain, she was taking acetaminophen and oxycodone, that's a weak opioid, so not quite morphine yet, but close to it. 2 tablets 4 times a day without much relief. 1 week ago, to develop sudden severe thoracic back pain. All the bones, especially on the back, Abdominal CT scan showed a mass in the head of the pancreas and showed a 4 centimeter diameter. So we have a liver, we have it in the bones. It's possible. And also the fact that she works, I mean, she's 59, so someone close to retirement and she's working. And if we read the next sentence, which is her husband, age 61, is a disability for the use of a transit company following a serious accident. He has a back injury and requires a cane to walk. He is 61 years old. So what is that telling us? She's probably the main source of the household income, right? So absolutely, so you're identifying already social pain. Come on, Mike, join the fun.
I will. Come back here. All right.
They have 3 children. So we're discussing the case of Jennifer. She's 59 and she has cancer in the pancreas, disseminated to her bones, her spinal cord, the vertebrae, and metastasis to the liver as well. So we also know that she's currently working. She works in a pharmaceutical company, and her husband is on disability at home. They have 3. Oh, he has a back injury, and he requires a cane to walk. So probably she's the main person functioning in that house. They have 3 children: a married son, a daughter who just finished her master's degree in psychology, and a 14-year-old daughter with Down syndrome. They attend church infrequently. Jennifer's mother is alive and living in a residential home with mild dementia. Her father died 10 years ago with lung cancer. She has 2 siblings, and then via some of the domains that we discussed today and yesterday a little bit. So you were saying social pain. So what are, if we go to this table over here, and we don't have to follow the order, but if we go to table here, let's go to the social because that's the one that you started. So you want to write some of the things here. So what are the social contributing factors to her pain?
Obviously her husband's disabled. She's the financial, she's a main breadwinner.
You have to tell me your discipline.
Social work.
Social work, okay. So we are a team here because we're physicians and nurses, so we all have to kind of bring our own expertise into it. So excellent.
There's been the child with Down syndrome.
We have a child with Down syndrome, and we have a mother, right?
And we have a history of the lung cancer in the family. That
So we have.
And yeah, that's right. The mother's at the residential with the mild dementia.
And probably she's also dependent on
yes.
this woman.
So this woman is taking care of her husband, her mother, her child. And she's the financial.
She's a very good financial.
And hopefully the medicine, insurance is probably through her work. Yeah.
It's very possible. She's 59, although he's a disability, but yeah, that's possible.
Yeah.
Minimal support.
Yeah, infrequent.
For your church, doesn't talk to her siblings.
She does have 2 children, two grown children, right? So maybe
Two
that's a
grown
positive.
children.
Would that be a positive?
Yeah, that would be.
So can we say that that's part of a goal? So what would be our goal to try to help her out if we transition from our pain issues towards trying to help her on this particular setting?
Coordinating our support system with the children that are
Right. So maybe empowering the children to become, caretakers to some of the responsibilities that she currently has. So that would be one of our goals. Okay. What else can we help her with at that point? We have a person who we agree is terminal, right? So what do we do with insurance purposes?
referral, palliative care.
Hospice referral, definitely. We're not there yet.
Okay.
We're
But
just
the
meeting with her.
pal-
But hospice is a goal, absolutely. I agree with you. Right, so can she be, my social workers, can she be on Social Security?
Depends on what her diagnosis was and the disability. Yes, it depends on her quarters worked and all that. Yes,
The
but
quarters.
she might have long-term disability from her job. So that insurance, the short-term disability, the long-term disability, and then
Excellent. And we can see how many quarters this she works. Maybe she could qualify for Social Security and Medicare.
why
Excellent.
the disabilities are all kicking in.
Excellent point. So that's a goal. So we need to try to get some of that income for the family so that doesn't affect her anymore, right? Excellent. Anything else socially there?
Well, the fact that she's an infrequent church member doesn't necessarily give us a state of her faith.
Right.
We know a whole lot more about who she is as a spiritual being.
Right, you're a chaplain, right? So let's go about spiritual faith. Excellent point. So yes, we do know that she frequently visits her church, but she has too many things on her plate. So maybe that's just she has no time to do it, right? Or maybe she doesn't feel like going because of her cultural issues. So maybe we need to explore what are her spiritual beliefs, right? So help me out. You're a chaplain too, right? So what else can we do to help her with that?
She may be still harboring something dealing with her abusive husband.
That's an excellent point. So we have a past, right? We have unfinished business. So maybe, and that's something that we need to address in the spiritual aspect of care. So you guys are chaplains, and we all as a team need to see that. So she was abused before, and we don't know what kind of abuse did she go through. Maybe it was, we don't really know. So we need to explore that part, and maybe have her to try to forgive, or to try to contact that old husband, or to try to explore what happened there. So that's a possibility. Excellent. Okay.
With her permission.
Oh, definitely.
I'm always like, don't be breaking that denial if you don't want to.
That's right. So just wait until she allows you to do so. Excellent. What else can we explore from her spiritual aspect of care? So, if we go to our psychological, and maybe we'll come back to spiritual, but from our psychological, what would be some things that will cause her great anxiety?
Care of her child.
Oh, absolutely. So the
Care of her Down syndrome.
the child with Down syndrome.
She dies in
So her child is the great concern. That's very good. What else? The mother, because we have a disabled husband that may not be able to get out of the house to go and visit your mother to care for her. We don't know who's paying for that long-term care facility, so that's another issue. What else? I'm sorry, her husband, of course, her husband may be very
So that creates her sisters and brothers that are not involved might need to get more involved with the mother caregiving.
Right. So that would be one of our goals. Maybe explore the relative side of the family and see if that
To relieve that stress from the caregiving of her mother.
excellent point. What else can we help her with anxiety? So we talked a little bit about the economical factor, different aspects of her job and all that. Anything else?
still fairly young. Her own losses of what could be or what happened.
Excellent point. Excellent point. So she's already grieving. She's already grieving. I mean, she may not know, but she kind of knows that she's very, very sick, and she probably is going to die very soon. So she herself is grieving for the loss of her life. She probably wanted to see her daughter graduating from her master's degree, and she probably wanted to see grandchildren, and she probably wanted to have her daughter with Down syndrome being not so dependent on her. So she's definitely grieving, and that's something we need to address as chaplains, as social workers, as the whole team. So now we're going to go a little bit into the physical aspect of her pain, and then what happened is that if we don't address the issues that we just addressed before, we are not going to be able to control her physical pain. That's just impossible. I have had patients that it doesn't matter how many milligrams of morphine we give them, if we just don't address other issues, it will not happen. We will not be able to control it. We will not be able to break their ice and to enter into a deep relationship with them and help them out. So that's why we need to have the core team, and we need to have this holistic approach of pain. So now we're going to go into physical pain. So what do we know from the history? We know that she was taking Vicodin, which is acetaminophen oxycodone, and I'm sorry, my chaplain and social workers are going to have to address this because we have a physician in the room, so we can know about the physical pain. Thank you. Yes, Percocet. But this was actually not working before, and then she presented to the emergency room. Yeah, and she had this new pain. So we know for a fact that this is not working. Now, does she have a reason to have pain? She has two reasons, right? We have fractured vertebral bodies, right? And we have cancer. We have liver pain. Well, actually, liver doesn't hurt. Liver capsule pain. We have bone pain, and then we have the pancreatic mass. So it must hurt a lot.
Bone cancer,
very painful, very painful. I don't know, I missed the first part of Beth's lecture, but I'm sure she talked about classification of pain a little bit, or did she? So it would be on the category of nociceptive pain, if you will. So it's bony pain, muscle pain is the one that I pinch on. If I do that, then I'm going to damage some tissue. So very, very painful, extremely painful. Because the tumor is fracturing the bones. So,
pancreatic cancer is visceral, severe visceral pain usually.
Definitely. So this is why you take your pain pills. You just put it like this, very nicely, and you put it on your pocket, and sometimes we have these pockets here, so it's just, that's the way we did it. So on the pain card we have, how do we assess the pain? And so, to assess the pain, who is the main person that needs to tell us about the pain?
The patient.
The patient, exactly. So if the patient is sitting there laughing with you and making jokes and he said her pain is 10 out of 10, what do you do? You believe the patient, exactly. Which many times my residents and fellows, they go, oh no, she's laughing, she's alright, we'll just give her time. And then, we have these fractures. Anyway, so always believe the patient. Okay. Now, what happens if we have a patient who has a history of addiction before?
You still believe them, and you know that the meds are not going to work as well.
So what do we do?
So you have to give them a higher dosage usually.
That's right. Excellent point. You don't know. So excellent. So higher doses of medicine.
Personal experience with pain.
So higher doses of medicines are required. So that doesn't mean, oh, you're a druggie, I'm not going to give you any medicine. Absolutely not, because they have higher tolerance to opioids. We need to give them more, actually. So sometimes the nurses call me from the floor, you ordered 500 milligrams of morphine every 4 hours. Are you insane? I mean, no, not really. That's what the patient needs. I mean, and so they all the time call me, are you sure? Yes, I am. So anyway.
Would it be accurate to say that if addiction and higher tolerances were a concern, that they're so secondary to everything else that's going on, they really don't matter?
So you're touching a very important point, and especially my older adults, my older patients, they think, oh, if you give me morphine or morphine-like medicines, I'm going to become a druggie, and I don't want to become addicted. So this is what we know about addiction. If you give opioids to a patient who truly needs pain management, the chances of their becoming addicted, if they haven't been addicted before, are 0.1%. So 1 every 1,000 people will become addicted. So the risk, if I'm not going to be treating cancer pain because 1 every 1,000 people are going to become addicted, that's very, very low risk. If somebody has been addicted before, the chances are 1 in 100. So very, very, very little.
And it takes a time span for that, correct? It probably of several months before the addiction process kicks in. Is that right?
It actually,
or no?
not really. It doesn't have to take a long time. But I really have not seen the first
persistent use over a period of time.
a period of time. Yeah. I really haven't seen the first case of addiction induced by opioids. So I've yet to see it. I prescribe a lot of opioids, but I've yet to see it. So I'll let you know.
Okay.
Yeah, so many of our patients will know. Okay, so going back to our patients. So on the pain card, we have these very nice scales of pain that you are very familiar with, I'm sure. And it goes very easy, from 0 to 10, so 0 no pain, to 10 the worst pain experience, to the 1 Baker phases. They were created originally for pediatric patients, and now we use them in a patient only speaks other language, for example. The other one is to do the functional stuff. So were you able to, play golf before and now you're not able to get out of bed? That's a very significant change. And then we have our very nice table here. And for my clinicians, all you need to know is that 1 milligram of IV morphine is equivalent to 3 milligrams of morphine. That's really all you need to know. Other than that, just go up and down the table. And you can carry this forever. If you take the boards, they will give you a conversion table, so you don't have to worry about anything else. You can always look at it. Is that clear? What's your name again? Elizabeth. So let's say that, what are we going to give her then? If I couldn't, if I purchase it, you want to give her morphine? So how much morphine would you give her? What do you all think? She's on oxycodone and she's taking 2 tablets 4 times a day. And let's assume that was oxycodone 10 milligrams. So say it's the highest dose. So say that she was taking 20 milligrams Q 4 hours of the she was taking, so she was taking 20 milligrams, so 2 tablets of oxycodone every 4 hours. So she was taking how much? 126 doses. Right? So 120 milligrams of oxycodone, right? And then we're going to switch that to morphine. So how do we do that?
Well, according to this, if her pain is classified as severe, then somewhere between 15 and 30 milligrams 4 times a day.
That is a way, but we're going to practice just another way of doing that. I'm just trying for my clinicians to use.
I'm going to put her on long-acting Q12 with breakthrough. I'm the equivalent to 120 over, and I'm going to put.
So let me talk about long-acting for just a second. On this particular patient, she is a functioning patient. She talks. She's able to communicate. So long-acting is a good idea. Generally, I think she probably has a good kidney function. So I would definitely use sustained release. I agree with you. If I have an older adult with very bad kidney function that is not able to communicate, and I don't really can see their mental status very well, I don't typically use sustained release right away just because of that reason. So I agree with you. Sustained release is like we need to calculate the total dose before. So 1 step behind. So let's go back here. So 120 milligrams of oxycodone is equivalent to how many milligrams of morphine? So we'll just go up and continue.
120 of oxycodone.
That's fine. Is equivalent to how much more? 180 of morphine. Elizabeth, are you following? Yes. So if you're here, oxycodone, 20 milligrams, and you multiply that by 6. Yes, because that's what we're getting, 120 a day. That's the same as 180 of sustained of morphine or any morphine. This is the trick. When we switch from one opioid to another, we decrease the dose about 50% to avoid cross tolerance. So instead of giving her 180 milligrams from the beginning, we decrease the dose to 90 milligrams.
Strength it down? 50%.
50%. But you can always go up. But if you want to avoid, what is the side effect that we are so concerned about? Everybody.
Lethargy.
No, addiction we talked about that, that's something else. No, what is the side effect that opioids will have? Respiratory depression. That's a big deal. You know, my residents don't want to prescribe morphine because they would get respiratory depression. So what is the, so because to avoid respiratory depression, you always have to increase the dose when you switch from one opiate to another. Is that clear? So now we have 90 milligrams of morphine a day. So Mike had a suggestion of having sustained release. So how do we do it?
Just half.
So we can do 45 every 12 hours, or we can do 30 every 8 hours. We can do that too, right? Is that clear? Teresa, you okay with that? Elizabeth? Okay. Sure. It's very important that you understand this, so we can go back if you want. She received 20 milligrams every 4 hours of oxycodone. That was what they told us here. So she's getting Percocet, which is oxycodone acetylcholine. So we calculate the total dose a day is 120 milligrams. If you go up to the morphine, 120 milligrams is equivalent to 180 milligrams a day. Is that correct?
We haven't really factored that in. Okay, so just the substance. That's the pharmacological stuff I don't know anything about. How does it work? How does it take?
Any questions so far about the conversion? So we decided on a dose, right? So we have 45 milligrams every 12 hours, right? Right. So we'll do that. So, and now, what if she has extra pills? So how do we calculate the breakthrough dose of the rest of the dose? 10% of the total dose, which is? But I'm not going to tell my nurses to go 9 milligrams, right? Because they'll be very upset. So 10 next to
Tablet very carefully.
Yeah. So it would be 10 milligrams, right? So 10 milligrams. And based on what Dr. Filan said, how often can we give that? Every hour, if it's IV or sub-Q, and every 2 to 4 hours if it's PL, just based on the half-life. So any questions about that? Thank you, Mrs. Elizabeth, Teresa, any questions? No? You okay? So I think that with this, she would have fairly well controlled regimen. There's some things that could help us to find control. So for body pain, for example, Tylenol is excellent. You have a good liver, you are Tylenol, and don't go into days with more than 4 grams of Tylenol. That's a good thing. You can also have NSAIDs, which is good kidney function. So your regular Motrin or ibuprofen, Naproxen, anything like that. She has a good, she doesn't have a history of ulcers or diarrhea, which is a good kidney. You can do that too. We sometimes use biphosphonates, so acrylidronine or any of the biphosphonates we use. I know in hospitals that's a little bit more expensive, but at the VA we could use it. So if you have VA patients and they're having a pain crisis, you can let us know and we can provide that.
We use something for bone pain with great success in Florida and it's in India right now.
You can use myoplastic spray, the nasal spray, and you can use that one.
What is it?
Myoplastic spray is acetylcholine spray. It's not FDA approved, but there are some studies that we have that they have done. So that's very good.
What are other names for biphosphonates that I might recognize?
Chaplains, I didn't mean to ignore you. I know this is just medical therapy, but it's important that you know the terms because when we're talking about fentanyl, we're talking about morphine or oxymorphone or whatever, and you're going to go, then everybody's going to ignore you. I mean, the physicians and nurses are going to say, oh, these people, they don't know anything, just go and deal with
But the
medical.
family needs us to understand, so it alleviates their anxiety.
Absolutely.
When they ask these questions and they don't feel like they're being stupid. And when the social worker and chaplain, I don't know, it feels like it alleviates the anxiety that I'm not done. I'm part of the process.
Absolutely.
When they're
they may
there
not-
with them.
They may not want to question the nurse.
Whether
You know, they're like, oh, well, she's a nurse and she's talked to the doctor. But they may say to you, hey, what do you know about it?
Right, or then they look at the jacket and they go, did you understand what they just said? And you know what I mean? The nurse can say, oh, that's just what I meant. It creates conversation.
Absolutely, absolutely. No, it's
So I appreciate the
so
conversation.
no, it's important that you know the terminology. It's important that you know what's going on with your patients. It's important that you know so we can help them out as a team. It lowers their anxiety. It lowers the level of knowledge and so forth. So that's very important.
So your meds were good.
And now something else, for example, my social workers sometimes do is, you know, like say one of the patients have the daughter's graduation, daughter's quinceañera, that's a big one, and they want to dance with the daughter, and so my social, I've never done this before, so my social worker goes, can they take an extra dose, you know, right before? I'm like, yeah, of course I can take an extra, but I wouldn't think about that, and my social worker did. So those are things that it never occurred to me, but as a team we can all think about it. You know? And so, you know, so those are, it's very important to have a whole patient assessment with an interdisciplinary team. So I think we went over the treatment summary. We went over the physical, psychological, social, spiritual, and I don't think we're going to go to the last session, but just a little bit about decision making. So it's very important that that we deal with her advanced directives, because we don't know if she trusts her husband or if her husband is able to make medical decisions for her. And being the next of kin, we don't know actually she comes from China, so we don't know how acculturated she is. And if she know, maybe she in China they believe that the husband owns, you know, or they make the decisions and that's the end of it. But maybe we talked a little bit about, you know, is your husband really able to make medical decisions for you? Is that what you want? Oh, is it a burden for him? Maybe your daughter or maybe your siblings or somebody else can do it. Maybe transfer the power of attorney from the mother to somebody else. You know, planning who's going to take care of what. Even planning your funeral is something that is very important. Yeah, absolutely. The culture is going to be very different, so we have to deal with that. Religion, we don't know how religious she is. We don't really know if she had any Christianity, and maybe her husband is the one that experienced that, and she's just kind of going along with him. We don't really know if that's her value, so we just need to explore that. Very good. Any questions about this case? I know it's a kind of a complicated and quick, very local case, but I hope that was helpful to you. Would you like to
put in all the aspects. It's a very rich case. It's got every detail you could throw in there. That's good. Otherwise, if it's a nice, clean, tidy case, nobody gets to do anything.
Right.
We don't think about this.
And believe me, we don't have any clean cases in hospitals in Palliative County. You know that already. So,
This
so
is not tidy.
No, it is not. We're not a tidy type of team. Yes, I'm gonna go. Okay, but thank you very much. Thank you. Start this lecture out.
So what's the medicine?
This one.
Another brief lecture, and then you'll get your 30-minute break. Veronica's part again. I'm really glad we had those small groups this morning. That was really interesting for me to see everybody's opinion and so forth. I think y'all are getting the general idea of, if you hadn't already, of you know, palliative medicine, what we're trying to do, our goal, and so forth. Yes, ma'am. No volume. Anxiety in our terminally ill patients. So again, to identify depression, anxiety, delirium in these patients and describe different management plans, which could be a little different from those that are not terminally ill. This was actually astounding to me. The percentages, 25 to 77% of patients who do have some sort of identifiable depression, whether that be mild depression, major depression, with or without suicidal ideations and so forth. But still, that's pretty astounding. And if you think about, you know, especially for younger patients, especially those who get terminal illness without any further notice, cancer, or so forth, you probably have an expected higher percentage. A lot of intense suffering. You know, we talked a lot about in our small groups this morning about pain management. And I know the case that we had with the metastatic pancreatic cancer, you know, coming out of nowhere, having such a serious illness with not a lot of options for cure, that the suffering that the patient is thinking about, not just the physical, all about her family and everything else, would add to the depression. What's going to happen to me? What's going to happen to them? It's not inevitable. It is treatable in most cases, which is very good to know. And of course, early treatment is better. And identifying that, which is what we're here to do, is identifying these issues so we can bring it to the attention of the nurses and doctors so that it can be treated. Of course, we talked about pain is one of the big risk factors for depression. Physical impairment, for somebody who had a stroke, who was actively doing all their functions of life that they needed to do, driving, taking care of others probably, and then have that taken away where they have to be taken care of. That can of course bring on depression. Advanced disease, whether that be cancer, even heart disease is another one that sometimes people don't think about. They don't have the ability to get up and do that because their heart can't keep up with them or their lung function for whatever reason. And sometimes what we do, medications can cause some sort of depression. People, steroids and benzodiazepines like Ativan and what y'all may be familiar with, Xanax. Like I said, stroke, pancreatic cancer, or any cancer disease which can come on pretty suddenly and doesn't have a lot of options for cure. Spiritual pain. I know in our case scenario this morning, the patient said she didn't go to church very often. We didn't know if that was contributing to some previous issues she had with her own faith, and was this adding to some depression. Of course, if they had a prior history of it, family history, so forth, substance abuse as well could also contribute to depression. One of the big things that maybe all of us can identify is the patients that are having a lot of pain symptoms that may be out of ordinary of what we would expect. They always have this stomach pain that's there, and the medicine that's given to them just doesn't seem to take it away. Is there an underlying depression to that? Are they having, sad faces or flat affect? They just don't respond to anything. I underlined the word anhedonia there. Were things they used to enjoy before, like watching golf on television or having a nice ice cream sundae. They just don't seem to have any pleasure in that anymore. And I think that's one of the big identifying factors that I've seen that I have overlooked at times and then gone back to talk to the patient, and I was like, oh my gosh, this person may have been depressed. And I could have identified that before if I'd asked some more questions on what they enjoyed doing prior and if they still do enjoy that or not. Suicide is always a big concern for us. All depressed patients are at risk for this. Even those who do have a high, pretty profound religious background, they still do as well. We sometimes think, well, if they are very religious and so forth, they have somebody to talk to, they're not going to do it. Everybody is still at equal risk and needs to be assessed for suicide. Especially if they discuss suicide, they have a plan, recurrent thoughts of it, so forth. There are several medications we can do. We don't want to exclude psychologists that can have group therapy, cognitive therapy, so forth, just kind of having the patient get it all out, so to speak. Let's talk about this, let's talk about the pink elephant in the room. You're down, you have this horrible disease, let's talk about it, let's get it through it. Medications, and then of course a combination of the two always help. The goal of counseling is to make it part of the whole treatment plan. We have the interdisciplinary team, which is great. So if we can just make them another part of the whole treatment plan, it doesn't seem like it's out of the ordinary that the patient is going to be doing this cognitive therapy. And some of the medicines that we can look at, psychostimulants. Let me go back there. Psychostimulants, SSRIs, which y'all may know as like Lexapro, Paxil, so forth. Tricyclic and atypical antidepressants, which we'll talk briefly about. You want to look at these medicines, physicians look at them by how long does it take for them to go in effect, what are the side effects, are they interacting with other medications that they're doing. Usually we try and start low, go slow, and if things really are looking bad, we would consider talking with a psychologist or psychiatrist as well. The psychostimulants, the one you may know of pretty well is Ritalin or methylphenidate. Very nice because it does act very rapidly. And 5 milligrams you want to do maybe in the morning and in the afternoon to kind of give them that extra little pep during the day if they really, really are done. These are for the patients that really are severely depressed. They can be used alone or in combination with other antidepressants. Now, one of the concerns is, do they have a substance history with this? I actually had a patient who did use methamphetamines illegally prior to being diagnosed with his cancer years before. When I saw him in ECTC, he was very down. He wouldn't even get out of bed. I talked with my attending and we said, let's give it a try, see if it helps. He improved so much within the next couple of days. He was able to go home on passes with his wife. They had a wonderful time with the family on the weekends. And eventually, when his cancer came to be more progressive, he did pass away. But at least we gave him that extra 2 weeks of time with his family because we were able to give him this medicine and it worked so well for him. Sometimes when you do use like the Ritalin, you can also have some pain effects as well. You have diminished opioid sedation. So the sedation that you can get with opioids, and we talked about it, I know in my group, that can happen. The psychostimulants like Ritalin can help with that. So another positive. You want to be a little concerned for those who have a history of anxiety or tremulous or even cardiac issues because it can make them worse. SSRIs, for example, like Lexapro or Paxil, medicines you may have heard of, Zoloft, they are very effective as well, 70%. Unfortunately, they take a little longer to kind of kick in for patients. They are well tolerated, usually once a day dosing. And you can actually start pretty low and get a pretty good effect in low doses. Tricyclic antidepressants, not usually recommended as first line. They usually take a little longer as well. Nortriptyline, we kind of prefer a little more. It's not as sedating or have as many anticholinergic effects as some other ones. And so some other antidepressants are being studied. There's trazodone, there's meperidine, and so forth. Anxiety is another big issue. Again, the fear of what's going to happen to me, what's going to happen to my family. That's seen a lot, especially one of the identifying factors is insomnia. I just can't sleep at night. Well, is it because you truly have something going on, or is it just that you're worried the entire time about what's going to happen to me next week, what's going to happen to me, how am I going to die, what's it going to be like? And again, the therapy, I think, can help a lot with that. Just talking through the patients, what are your concerns, what are your issues, and you can see a lot of times the anxiety will be helped. They can present with agitation, insomnia, as I said, restlessness, tachycardia, very fast heartbeat, hyperventilation, panic disorder. You want to differentiate the anxiety from delirium, which we'll talk about, and depression. There are some patients who may have a history of bipolar disorder, which could be, they're manic. If they're in their manic state of bipolar disorder, that can be confused with anxiety. Some medication effects, if they're on albuterol treatment for some lung issues, that can make them feel a little nervous at times. And then, of course, if they're using a lot of caffeine or alcohol, that can also be a cause for anxiety. Again, the counseling, like I talked about, is very good. Just getting it out in the open. Benzodiazepines like diazepam or lorazepam are very good. They act fairly quickly. You kind of choose which one is short half-life or long half-life. If somebody's having a little problem sleeping at night with some anxiety, you may choose one that's a little longer that can last through the whole night. If it's just a very episodic thing, you may want to choose one like lorazepam, which only has half-life of maybe 3 or 4 hours. So this is what I really wanted to focus on a little more, because I think depression and anxiety we probably identify fairly well. But delirium is one that can catch us off a little off guard, especially because somebody may have been doing pretty good and all of a sudden they start acting a little strange. So this was a case of Ms. P. I actually briefly talked about her yesterday. She's a 75-year-old female, had a history of non-small cell lung cancer with metastasis to the bone and her subcutaneous tissues. She also had lung disease, COPD, she also had heart disease, coronary disease, and bipolar. So she already had this history for quite a while before her lung cancer became pretty severe. Medications she was taking, methadone and morphine for her pain. She was on Conoco too because of her COPD and because of her lung cancer. And psychiatry had her on citalopram and dicipramine. Dicipramine is an atypical antidepressant, and citalopram is one of the SSRIs for depression. So that's the way she was being treated for her bipolar. She had mostly depression, but she was, at times, could get in a manic state of mild mania. But that was pretty well controlled. So, patient was admitted to a long-term care facility, the hospice unit here at ECTC, and she had been stable for about 9 months. She had had a little bit of progression of her cancer with pain, and we were working with that. But as far as her cognitive issues and her function, she was actually pretty stable. She had her own room. She had it set up really nicely. She was, she was a decorator. She had done landscaping, and so she had it all decked out. It was really fun to see. And she had a great personality and could talk to anybody, it seemed like. So she was down there for about 9 months and really no big issues. She started having a little bit more respiratory about 9 months into it, and we started her on some steroids, hoping to ease that a little bit for her. And then we noticed that her calcium level was increasing, and she was starting to have a little bit more dehydration. And this was probably from her lung disease, her metastasis, so forth. And of course, because of all this, she started having a little bit more increased confusion and was wandering. She had a scooter that she would go around and go play bingo and so forth, but in the middle of the night when somebody's rolling around the ECTC hall on their scooter, the nurses don't really like that, and so she actually had to take them away. They were actually concerned that she was going to take the scooter somewhere down the hall, start walking, have a fall, and then have a lot more problems that way. So we had to suspend her from her scooter privileges at that time. So delirium, this is what the patient was having, global change in cognition, awareness, and acute onset. She had no idea that this was a problem to go out in the middle of the night on her scooter and to start talking to the nurses about how she was going to have dinner with some very important person the next day or so forth. She was really confused on the whole situation, and she actually thought it was 2 o'clock in the afternoon when it was actually 2 a.m. in the morning, and they were trying to get their work done. But she did have fluctuating levels of consciousness. We'd go and see her the next morning after she had this episode, and she had no idea that this was ever happening. She's like, "What are you talking about? I had a wonderful night here in my room," and was very pleasant about it. This is very important to distinguish from dementia, depression, and of course anxiety, the other 2 things we talked about. Having known her for the 6 months prior to this happening, you knew that, yeah, she was a little eccentric, so to speak, but she always was orientated to time and place. She always had appropriate answers to questions. She, had a good, it gave you a timeline and everything that happened, but you knew definitely something was going on when she was going out on her scooter and had no idea that this was happening. So what were we considering why Mrs. P was having these issues? Well, the first thing you would think, of course, is infection. As I said, she had this lung disease. Did she have a pneumonia going on? Another common thing in elderly patients is a urinary tract infection, so forth. Her vital signs weren't showing that she was completely septic. Blood pressure was stable, so forth. So we didn't think it was that significant, but we did do an evaluation looking for infection. We wanted to look at her medications. She wasn't on any street drugs, thank goodness, but for other patients, if they had been taking a lot of Ritalin on the side or whatever and suddenly came off of it, they could have some issues. Hypoxemia, of course, is another one. She had the lung disease, she had lung cancer. When she'd get confused, she'd take off her oxygen, and of course her oxygen level would fall, and that can of course add to her confusion. Or was there another metabolic state? How were kidneys doing? How was her liver doing? Was this adding to her delirium? Vitamin deficiencies, fecal impaction. I think this one doesn't go recognized as often. When was her last bowel movement? It seems like we're asking that every day. When was the last bowel movement? I know if I hadn't had one in a couple of days, I'd probably be cranky and confused. And thankfully she didn't have that problem. Urinary retention, also pretty common. The renal hepatic failure I talked about, tumor burden, secretions. Was the lung cancer causing hypoxemia? Was that causing her increased work of breathing, so forth? That was making her confused. We just moved her to an environment. Actually, the month before, she had gotten a new room, so she had already become accustomed to that. So we didn't think that was going to be an issue. But for other people who, let's say, were living at home and then the family can't take care of them, they move to a nursing home, for example, completely new environment. They have no idea what's going on. Nothing looks familiar, so forth, and that could cause them to be confused. Medical management. Neuroleptics is usually usually not the first thing we want to do. The first thing is we want to check for the other stuff and see if we can get it fixed. Remind the patient where they are, have somebody there sitting with them, reminding what day it is, so forth. If they are missing their eyeglasses or hearing aids, get that for them. Just keep reorienting them to time and so forth. But if it comes to the point where they're a danger to themselves or to others, then we probably look to medicines to help keep them calm. And haloperidol is one of the good examples. One of the atypicals when we look at is maybe risperidone or olanzapine. You may know this, like Zyprexa, risperidol, so forth. If somebody's having an acute agitation, we would also consider a benzodiazepine like Ativan, for example. So for Mrs. P, we encouraged her to keep her oxygen on at all times. We thought maybe her oxygen was getting a little low and it was adding to her confusion. And we actually had a sitter come be with her 24/7. She actually really enjoyed that because when she was in her fluctuation and she knew what was going on, she just loved having somebody to talk to all the time. And of course, they were looking out for her safety. We stopped the steroids. Her lung function improved, and steroids can cause some psychosis, some delirium, and so we went ahead and stopped those and just continued to monitor her lung function. We gave her medicine, some IV fluids to help correct her calcium. It had gotten up pretty high, and as that continued to go down, it seemed to improve her delirium as well. And we also started on her risperidone at night. Again, her major issues were at night when she was getting more confused, and we were really concerned, even though she did have the sitter, that something could happen she would do something to herself unintentionally. The next month, though, she did well on these interventions, but unfortunately the next month she had increasing hallucinations, rambling speech. She had decreased ambulation, and then it was completely bedbound. And it was really quite shocking to see how much she changed. Decreased appetite, and then she wasn't able to swallow her pills in the last couple of days. But she did die peacefully a few days later. So identifying that delirium, the month before when she was first having her agitation, and appropriately trying to treat that, keeping her safe, giving her mild medication as needed, correcting her calcium, taking her off medicine that may have been making it worse, probably helped to add to at least a few more weeks of comfort for her and her daughter, who was visiting her very often. So it's very important in all of these depression, anxiety, and delirium to monitor them carefully, reevaluate what's going on, see if there's any further changes that have happened. Of course, it's easy to say it's because her oxygen level's low, that's why she's delirious, but don't forget about the other reasons that could cause it: infection, calcium level being too high, or just the many other things that can contribute to this. And of course, if one of the medication isn't working, consider changing to a different one and refer to a specialist if it's needed at that appropriate time. And that is my summary. And I think y'all have a 30-minute break right now. Any questions? Thank you very much.
Yes.